of weeks' time is my 9th birthday as a medical photographer. I came in from an arts background, did my qualifications to get my clinical photography, and then started in the job. I felt a wee bit uncomfortable with, I had no science background at all, so I'd learned everything I needed to do my job properly. So we've got a thing, Open University in the UK, so I decided to start open distance learning degree. So for the last 7 years now, I've been working through healthcare science as a degree. And this year, the final year, is my dissertation year, and I got to do an exploration of my practice to pick an area that I really enjoyed and work on it to build it up. I like dermoscopy. And very early on in my career, my trainee position, the reps that sell dermoscopes had also been plugging them really hard all around Scotland. And my department had a brand new one in the box. So one of my first jobs as a trainee was, this is a dermoscope. Work out how to use it and make us a SOP. I really did that. Worked out how to switch it on, attach it to a camera, press against the patient, take a photograph, clean it all, and then roll a wee SOP for it all. Gave it back to the senior photographers, and then never saw it again. About a year after that, just after I qualified, I got my first full-time post, and I went up to Dundee, which is on the north-east of Scotland. And they've got a Centre for Excellence of Dermatology there. And they were very, very proud of their dermoscopy. And during the interview, they said, look, we're winning a lot of awards for our dermoscopy here. The consultants are really happy. We're really damn good at it. Do you know how to do it? And I was like, no problem at all. I wrote a SOP. I know exactly what I'm doing. So I went in the first day. It was a slightly different dermoscope. It was one of the behind Delta ones. And it was great. And the training was, so this is it. Your patient's here. Put some oil on the skin, press the camera against it. It was a wee point and shoot on the back of it. That's your photograph, move on. And that was sufficient, so it was great. Did that for 3 years, and I was really good at it. It was no problem at all. And I came down to Glasgow, which is where I'm working now, and my first day in the job, my manager was like, we've got this dermoscope, can you use it? And then just after a year or so into it, I started getting these kind of whispers coming back from the doctors, saying that they weren't keen on asking for it anymore because they weren't seeing what they were seeing with their dermoscopes. They would have a look through, see something that they liked, send it in for recording, and then get back a photograph that didn't match what they'd seen. It wasn't too helpful for them. What are the doctors seeing? So I thought I'll go back to the opposite way around, reverse it all, and I'll look at my project now from the doctor's point of view. When they're getting the patient in front of them, what are they looking for through their dermoscopes? And then what can we learn as clinical photographers about that? We'll do it that way, backwards round. So this is what we're doing here. So I've basically done a wee study there where I've explored all the methods that doctors would use in their training to interpret dermoscopy. And just make sure we're all on the same page. This is a normal close-up. I take it everyone's familiar with dermoscopy. Yep, good. And this is the difference on the dermoscopy of the same lesion there. So what we're going to do, I've said I've done interpretive methods is what I've done my focus on. But to understand that as I go through it, I will go through the dermoscopic criteria, and I've kind of consolidated down from the 6 different methods I'm going to discuss. There's a range of different criteria. I've tried to make it kind of straightforward enough. So we've got 18 criteria to show you all first, so you understand what I'm talking about. And then get down to the end. There's a couple of common lesions as well, so I'll give you some of the common morphology to look out for and that kind of stuff. And then I've got a couple of recommendations for how we can then apply this into our practice. And I'm going to give you one of the recommendations now. Because this presentation, I've kind of reorganized my dissertation slightly. So one of my recommendations is about training photographers to be more than just pressing against the skin. And it's actually about a more considered approach to dermoscopy. So this presentation is going to kind of take the form of a short, 15 minutes or so of how you could actually improve a little bit of knowledge about what we're actually looking through the dermoscopes and think a bit more like a doctor. And the reason it's 15 minutes is because that's what they discovered in studies was sufficient to improve diagnostic reliability when they did it with medical students. So we've got the morphology. So there's 18 features to look for. We've got 6 colors and 12 structures. So these are our 6 colors. So when we go through the interpretive methods, when some of them mention colors, these are the 6. So there's more than 6 colors, obviously, in the spectrum, but these are our main ones to look for. So we've got red, blue, and white, and then black, dark brown, light brown. Easy enough to remember. Irregular, multiple colors. Regression is a later stage in pigmentation that starts to fade away, and it's a bit more kind of grey and specky. Dots and globules, the wee blue-grey dots and blotches. It's all self-explanatory, really, isn't it? The dermatologist made it easy by making it look like describing those things that we recognise. Blue-white structures, this kind of blue colouring. We've got the streaks, and then we've got these pseudopause, these little white spots. Scar-like, looks like a scar. Vascular pattern, then we assume we don't see a lot of blood at the top of the skin, so anything that's on the top of the skin is very typical. And then we've got this nice broadening network of the vasculature that comes in lesions, so that's for 12. So here are the 6 interpretive methods we've gone through. There's loads and loads of them. We could do it for days going through interpretive methods, but I went for a nice wee kind of spectrum of simplest to apply all the way through to a little bit complicated math-based ones. And what we're going to do is I've got a patient I'm going to show you in a second, and we're going to apply each of these methods in turn to the patient so we can see roughly how dermatologists may actually use this as an analytical method. The first step is related to it. The second step is to use one of the other 5. So here's our patient. Does anyone think it looks good at the moment? I'm assuming nothing at all. It doesn't look too healthy, and we're thinking. So this is a patient we're going to work through anyway. We'll apply all the methods and we'll see what kind of come out. The aim of these methods is not really diagnosis as well. We're not diagnosticians in clinical photography at all. So we want to make sure that we're giving the patient, the doctors, the information they need to make their decisions and reassess the patient in the future, see if anything changes, or remove it altogether. So that's kind of the aim of these methods. So our 2-step method. First step is to decide if it's melanocytic or non-melanocytic. So if it's got pigment or not. If it has pigment, we then move straight on to one of the other 5 we'll come on to. So we'll go straight to the first one. Melanocytic, non-melanocytic. So what do we think for this one then? Melanin? Melanin. Super. So that's great. So that means we get to move on to a 3-point checklist as the first and nice simple method. So we're looking for 3 things, or any one of 3 things. So asymmetry when it comes into dermatology, to dermoscopy, is different from when we're looking at normal moles. We're not looking at the kind of overall shape. We're looking at the colours and structures within inside the lesion. So it's split on 2 planes. So we've got asymmetry in any of those planes. We'll give that 1 mark. Atypical pigment, multiple colours, and any blue-white structures we see in the lesion. So that's what we're looking for. We'll get back onto it. Any more than 1, we consider it suspicious, and the doctors probably want to remove it. So how are we feeling about asymmetry here? Absolutely. Atypical pigment. Yep. And I'm in 2 minds about this. Actually, I've looked at this lesion an awful lot. And blue-white structures. Yeah. Well, I think actually this probably is what would count. So I'm getting about a 3 out of 3. So it's not looking too good actually already. We only needed 1, so we're on to 3, so that's good. Now we'll elaborate a little bit more. So our 7 points. We'll see the dermatologists like to make the list nice and long here. So same idea again. So we've got the pigment, blue-white veil, vascular pattern, irregular streaks, regression structures, regular pigmentation, dots and globules. So we're looking for a score of more than 2 as indication of melanoma, which, by the way, actually is the main focus of all these. Really, we're looking for melanoma more than any other kind of skin cancer when we're going through this kind of method. So the first 3 are weighted as a little bit higher, and then we add any one of the extra ones onto, then we're looking at a melanoma type lesion. So here's your refresher. Assuming no one had forgotten anything anyway, so we're all good. So atypical blue-white structures, vascular streaks, regression, atypical pigment, and dots and globules. So we're really asking, we've got atypical pigment. We know that's our blue-white veil. If we can see a typical vascular pattern here, probably this actually. It was clear on my computer. This is the ulcerated part of the lesion actually, so that's tiny blood vessels that are coming through there. So I'm giving it full marks anyway. And we've got streaks, plenty of them. The regression structures are around this kind of side here actually, where we're starting to lose a bit of definition. We've got irregular pigmentation, and there are dots and globules and stuff going on. So I'm giving this a full, how many did I work out? 7, 2, 4, 6, 10. So it's more than 2. Now, Menzies method now. This one's a wee bit different. And we first start off with our negative features. So if any of those, if we say it's symmetrical and only has 1 color, then we don't bother with anything else after that. If we go into the positive, we've got the 9 features here again. And any one of them, it would indicate it's kind of suspicious. The Menzies is different. When we go back into the later point where we're looking at the features of common lesions, Menzies was the guy that wrote the book on this, actually, quite literally. And for each of the kind of common lesions, he's picked out kind of key morphology as well to look for. So when we go into that point, that's all his work as well, or his and his colleagues. Okay, so is it symmetrical? No, and there's only one color. Nope, so straight on to the good stuff. And very yes, we've got blue out veils, streaks. Can we remember the 6 colors? So we've got a redness anyway, it's kind of a little bit flushed. I would say we've got black, dark brown, light brown. We've got our white, and if we're going for a bluey veil, we could probably almost argue that's a bit of blue in there as well. This is a good lesion, by the way, it's got everything in it. So let's see, so we've none of the negative features, we've got at least one of the other features. We're still suspicion here, melanoma. Now we get to fun math stuff, and I've gone through the scoring table hundreds of times now, and I still can't remember all the scores, but we're weighting everything by its value. So we've got asymmetry, it's the same 2 planes of asymmetry, no planes of asymmetry. Borders, I'll show you in a second, is done by an 1/8. We've got our 6 colors again, and then we've got 5 dermoscopic structures, which I'll refresh. So for each of the values, we add them up, add the weighted score, and if it's higher than 5.45, and we're looking at melanoma again. So we've got the typical, symmetry, and then this is how we divide up our lesion to look at borders. So we divide it into 8s and count how many borders are odd. And then it's our 5 criteria for this one. So pigment, streaks, dots and globules, and I don't have a photograph for it, but a general lack of structure. I wasn't quite sure how to demonstrate that one really, but so we'll go through anyway. I'm going to say there's 2 planes of no focus of asymmetry. I would probably say there's almost no borders the same as well, so we'll go for, I'm going to give that a full 8. I'm feeling quite harsh to it now. Colors, we've got all 6 at least, and dermoscopic features is actually all 5 of them there as well, so I'm giving that a good 8.9. It's not looking good, so higher than 5.45. And then the final of our kind of acronym ones is CASH. And I also discovered going through this at dermatologists and medical people often just love their acronyms, and they had to throw in the word homogeneity, which is a horrible word, and but obviously it makes CASH. So going to colours again, architectural disorder is completely subjective really, actually. It's either it looks like a mess or it doesn't. Symmetry is exactly the same planes again, and then we've got 7 features of homogeneity, or lack of. Add them all up, score greater than 7, that's suspicious. So we're good, 6 colours. How do you feel about the architecture here? Does it look terribly organised, or is this disorder? Nah. I'm going to agree with you, yeah. And then we've got our 7 features. 17, yeah. Well, I'm giving it full marks for everything, to be honest. So it's, I like this one there. So we'll go for a wee summary here. So a 2-step method, we decided it was melanocytic. We went on to one of the other layers. For each of these, we can add them onto the 2-step method anyway. We're going for suspicious from the 3-point, melanoma, high likelihood of melanoma, and a suspicious lesion from the CASH method as well, CASH method. So ultimately, I had a wee look into the notes in this one, and this was a superficial spreading melanoma, which I think needed quite a deep excision to remove it all as well. So at least at the very least, I can show that all these methods were good at screening that one out. So it would have been removed by everyone who looked at it, I'm assuming. Now, after I did all this, wrote it all down, planned it all out, I went to all the dermatologists I work with, and I said, do you use any of these methods? If I give you your dermoscopy image, do you go through and go around colours, structure? Or from years of experience, do you just recognize lesions now? And there's been studies in this as well to do with heuristic learning versus analytical learning. So I thought I'll be interested to see how they do it. And almost every single dermatologist said, I've no training in dermoscopy, actually. I don't really know. I look in, I ask for them. It's not really something I care. A lot of my doctors don't request it at all, and the ones that do it for the record's sake, but are not that fussed on what produced because they've already made the decision. All bar 1 or 2 who are proper diehard dermoscopy fans, they absolutely love it, and they swear by the Menzies method. So he likes to go in, get rid of the negative features, and then apply the other ones. And I guess it was him actually started me on thinking a little bit more about this as well. And he's a big fan of this next section, which is the features of common lesions. And I found this is very useful, actually, for when you're coming to approaching this. A lot of this is based on the real-time application of dermoscopy. So when you're sitting there with the patient, doing it face-to-face, This is a truncated list of common lesions, I suppose, we come across, which have very key features on it that differentiate them clearly from other lesions. So melanocytic lesions, so normal stuff. Pigment network. And a bunch of other features as well, this kind of cobblestone thing, a lack of structure and stuff like that, all fairly straightforward enough. And seborrheic keratosis is an interesting one, and I didn't really spoke about it. I'm not going to go into great detail about technique and stuff like that, but you're probably aware there are different types of dermoscopy, and we've got polarized contact, and we've got non-polarized, which uses an oil substrate as a transfer contact medium. And for the most part, you can get away with polarized quite happily for almost every type of lesion. Seborrheic keratosis is a wee kind of quirk in it, but there's actually a huge benefit to having a non-polarized method as well. So we've got these little cysty type things, which we can see fairly well, okay-ish in this one actually. But if we had the non-polarized, these little cysty things glow to where the way the light refracts through the collagen in them. And it's a very quick way, because I mean, lesion by itself, just looking like that, going through our little criteria and stuff, that starts to look slightly like a melanoma. And that's what makes doctors referring in panic a wee bit, and they send it in. And with a quick flash of non-polarized light, you get these little kind of discs, little white spots appearing, very quickly differentiated from the scary stuff, and reduces the risk a little bit. And you get a lot of patients come in who have been not sleeping for weeks now because the doctors panicked and sent them in. And the dermatologists I spoke to all want us to know this, and they want other doctors to know it as well. Now, BCCs, there's a few features there, but the key ones, these arborizing vessels and a wee bit of ulceration, and these little blue-grey nest things. So if I get a suspicious thing with a BCC, that's what I'm looking for straight away, because we see them all the time in these. So SCCs and keratoacanthomas are very, very similar. But when we get an SCC, we're looking for these little hairpin vessels in the kind of milky substrate. So it's easy enough. You get a SCC, that's what you look for to focus your photography on, I guess. This is a good way of approaching your dermoscopy, I suppose. Keratoacanthoma is slightly different, though. It looks always exactly the same. Still got the big keratinous plug in the middle of it, but the blood vessels appear slightly different on the top. Just almost the first one without melanin, actually. So we've got vasculature here, and these nice little kind of blue-white areas. So hemangiomas, things like that. And then we've got the melanoma again, which we list there is actually the same as a 7-step checklist. So based on everything I went through in my dissertation here, long analysis of all these different methods and stuff like that, I came up with a couple of things I thought we should do to kind of start to improve how we approach this now within our practice. And the first one I've just gone through here is this kind of very basic training, just so that you start to recognize atypical structures, like colors and stuff, that kind of guide your approach to patients. It's all about real time. And then my second recommendation was about enhancing the images a wee bit. Now, one of the studies I came across there, they did the basic training, same idea, teaching a bit of morphology to medical students, and then they assessed them in color, but then they assessed them in black and white as well, and they found that there was some complete correlation that morphology had so much precedent in these methods that color was definitely secondary. So that's given me the confidence to say that I think we can start to boost these images a wee bit here to bring out all the morphology, so that's very, very clear to doctors, push it right in their face. And as long as you're not going mental with Photoshop filters and stuff like that, the colors will stay relative, but really want to see the structures underneath. So there's my two recommendations here. So we've got the real-time stuff we do with the patients. This is the first lesion I showed you right at the beginning, actually. Out of interest, now I've gone through all those different lists of morphologies and colors and stuff like that. Are any of you looking at this now going, I can see a wee bit red in there, and look at that white halo, and that pigment's a bit funny. Is that some dots and globules, or are we feeling we're seeing that a little bit different now than we were beforehand? That's good. So all I'm saying, recommending from this one here is that next time you're in the clinic and you've asked for your dermoscopy, I should say this is actually, we've got the clinic-based and also teledermatology-based as well. And the clinic is a little bit easier because they give you a bit of a cheat because the doctor's already got an idea of what they're sending to you. If you are out in the community and you don't have a doctor first, you come with a nurse, you've got a patient and you've got no idea what the lesion is, they've said it's probably unusual. it's nice to be able to apply this and go take it step by step, I suppose, and go in with your 2 steps, go, is it melanocytic, is it not, and then put in your head what you expect to see at this next point. So are you going to see blood vessels? Are you looking to see little spots? Are you looking for colours? Just a slightly more considered approach to it all, I suppose. And then just think, once you've got into that point, so like I was talking earlier on about being trained about oil on, press the camera against it, and take the photograph. But we're missing so many little subtleties here. Apart from the very obvious thing here that with the polarized, you don't tend to need to have anything in between. That's the whole point of the polarization, is to reduce the reflections. But sometimes parts of the body, you've got dry skin and stuff like that, and we'll be losing a whole bunch of information around here. So a wee bit of oil doesn't do any harm there, and it's given much clearer dermoscopy. But there's also this vascular blush as well, which is so delicate. When it comes to things like your BCCs, you've got the wee rising blood vessels, which sit in the top here. They're very small and fine. If you just whack the dermoscope on, you lose them altogether. It doesn't necessarily change the how the doctor interprets the image. It would be nice to give them both options, I suppose. And if they're not there, I say teledermatology, where they're looking at these photographs later on in the patient's notes. It'd be nice for them to go, I'd like to have seen that with less pressure. So it's just an extra thing I want to throw in to think about there. And then it's the post-production stuff. So like I already said, morphology, taking precedence over colour. And I do like to boost my images to make sure that the stuff is very clear. I don't want to give any ambiguity really at all. So so I like that one there is fair enough. When you look at it close enough, you can see little structure and stuff on it. But I think this is far more useful to present to the doctors and well, the ones I spoke to, it makes them happy. And I guess once you start boosting it out as well, they're starting to see things they're not seeing with their naked eye. I mean, there's a limit to how much your eye can compensate for the kind of overall pinky cast in this one. Where this really, rubs it in their face. And one of the doctors came back the other day to tell me he'd seen one of these photographs and realised what he thought were cysts were actually sweat pores. And it was down to it boosting the contrast was what gave him that extra clarity he hadn't seen with his own eyes. And with that, I wrap up with that one. Thank you for listening.